afternoon, everyone. Welcome to the Planning Ahead session, a platform dedicated to equipping you with the essential knowledge and tools to navigate critical aspects of your future. Today's session is of paramount importance as we delve into three crucial topics: financial and legal considerations, maintaining accessibility and independence at home, and accessing palliative and hospice care. Our esteemed speakers today are true authorities in their respective fields, prepared to share invaluable insights to empower you in planning for the future with confidence. Spencer Deal will enlighten us on the intricacies of financial and legal matters. Erica Pitch will guide us through the nuances of maintaining accessibility and independence at home. And Claudia Chow will provide invaluable insights into accessing palliative and hospice care. So please join me in extending a warm welcome to our first speaker, Spencer.
Good morning, everyone. I'm just going to go ahead and share my screen so that you can see what I'm seeing, and then we'll begin from there. Okay. I believe we have you all set up here. So I'll start with a few things. My name is Spencer Deal. I'm a social worker, a clinical social worker with Vanderbilt's Medical Center. And so I work in our neurology department. I see patients primarily with our Huntington's Disease Center of Excellence, but I also get to see patients in our other populations as well, and get to work with some patients with multiple systems atrophy or other neurodegenerative conditions. And so today I was asked to speak about legal and financial planning. I will give you a bit of a heads up. So the reason for that being that there's all kinds of unexpected and anticipated or expected changes that happen in life, but also when we have some known medical conditions, something like multiple systems atrophy, that we want to know how to prepare for. And so with my work in this environment, I will say my training is as a clinical social worker. So I'm not explicitly a financial advisor. I am not an attorney. I'm not a licensed lawyer. So knowing that these are things that are based on my experience and knowledge and just familiarity with some of the systems that people access when they're going through these things. So that's where my knowledge is coming from today for you. And so I'll give a bit of an overview, but I'll give you a heads up as we're starting. This presentation has a lot of information in it. So I'm going to move through it quickly. There's more on the slides than I'll say, but I want to have this for you as a resource that you can go back to. So I'm hoping we can share those slides with you, but I'll also be glad to answer any questions when we get around to our Q&A. So to start with, really the things I'd like to do are talk about what kind of changes we expect with MSA. You may know about some of these, or other presenters may have shared things with you about these, but I'll kind of talk about them as they relate to finances and legal, what kind of ways we can anticipate what needs we might have with those changes, how we could plan for them, what types of planning we might engage in, and then what resources are available to support us in those, because this is a complex process. So with that being said, some of the main changes are that we may see differences in our functioning. So that would be the ways that we typically have operated, the things that we've done. That could be, in our next point, our work or our vocation. It could be our physical abilities. Any of these things that are altered over time, either just with typical life, but also when we are coping with a illness. So these things will change our goals. And so the main thing I want to drive home here is that our finances, our legal decisions, these are actually about our goals. They're about what things we want in life and what we're hoping to attain. And so those things may change with time, and that's perfectly okay. But we want to anticipate that. We want to know those may be things that we reevaluate or reassess. It may change our ability to work. So that's our income stream, what type of vocation we've had. And those are things we'll talk about. May change the ways that we seek and receive medical care. That may increase, or we may see different types of providers. So we want to plan for that. We also may be relying on our community more for support, and those are people we want to involve in our financial and legal planning, because they're people that we want to trust. We want to be able to share this information with to make sure that our goals are met and that our wishes are carried out. And lastly, we want to think about what actually gives us meaning and purpose in life. And this is a very important subject to me because I actually think it informs the rest of this. And so, we can have certain goals for our life. We can have different ideas about how we do things or what we want to do, but what our purpose and what our meaning is at different points, because again, this is something that is overarching but can change with time. We want to think about those things when we're planning for the future. So what things might we anticipate when we talk about these types of changes? So first and foremost, or at least at the front of many of our minds, is our medical expenses. And so these are kind of direct costs. These are things that we might be paying for at different points out of pocket, or using insurance plans or other savings. So this is kind of a short, non-exhaustive list of those things. But to touch on them briefly, we have medical visits and all of the different orders and things that come with that. We want to think about how we're going to pay for those. In-home and long-term care services are actually very specific in the ways that they can be paid for, and they can be very costly. So we want to think about what combination of services or financial tools do we use to cover those. Anything unexpected or things that pop up. So that's going to be kind of like our emergency or available cash just on hand. And then from there, we want to think about what kind of legal support we need. So these may be ways that we describe what kind of medical care do I want, or what kind do I not want? Who do I want to help me make those decisions or make them in the event that I can't? And then also in the event that I have changes that mean that I need access to, for example, Medicaid services, which I'll touch on a bit later, we want to think about how have I arranged my estate? How have I arranged my assets, the things that I possess or own, and want to use them either for myself or for the people around me. So I touched on these briefly, but our types of planning, we could say, is our financial and our legal. But then within that, we have a couple of different categories. So we have that cash, what we have immediately, what we may need at different points to fill gaps between other services. We have our retirement savings, which is long-term. This can come through a lot of different places, but these are things that we may consider accessing at age 65 or around then when we would consider retiring, but also may utilize earlier if we need to, in a medical situation where we have changes in our ability. We may use insurance benefits, and I'll talk about both of these, but typically we think about specialty insurances and then health insurance. And then also any public programs, Social Security being one of the biggest ones, that could be either retirement benefits, or it could be things that are based on disability or income. So we'll talk about those. As far as our legal, these are specific documents that I'm referencing that you would want to consider completing, specifically a durable power of attorney designating somebody, or an advance directive. I'll get into those a little bit more. You may have heard of those terms before. And then an estate planning or designating trusts. And those have different uses, and you'll want to think about them differently depending on timeline, what things you may need access to at different points or may want to remove from your list of assets. So we'll touch on that as well. Okay. So when we're developing a plan, we want to work with professionals. We want to work with people that are well advised about these things. The key from this slide is really that you want to work with people that you trust. So could be family, it could be a trusted advisor, somebody that will not have a financial interest necessarily in your decisions. So you would want to think about, how can I make good decisions about my finances without somebody that's trying to sell me a product or get me into a situation where they're benefiting from these changes that I'm trying to make to best serve my family or myself. When I'm thinking about those things and when I'm working with a professional, I might try to begin by thinking about, what are my financial goals? Like, when do I want to retire? Do I want to retire? What expenses am I already noticing that I'm going to be needing to pay for? And is there a pace that's been described by my medical professionals about when I may need to think about different types of services, being different medical therapies, using in-home or a facility for services to live in? So that could be skilled nursing or things like that. So we want to kind of have a broader timeline in place. And I'll say this is a complex slide. There's a lot of info on here, but again, this is a resource. So I'll touch on a few of these, and then please feel free to reference back to these as well. You want to think about some of these financial services as overlapping. So no one of them is the key to getting everything right for your financial planning. we want to kind of cover what different types of risks, different things that we've been anticipating or may need to adapt to with a combination. And so that's going to be these different financial tools, which what's listed here are different retirement accounts that may be available. They could be available privately or through your employer. And some of them will have different advantages based on when you expect that you might use them. So when they're taxed, or when you have access to them, if it's before a certain age or after a certain amount of time. I've mentioned private investments here as well. That could be things like trading in the stock market, but just noting if you use those, they have different levels of risk than some of these other financial products, which are managed by someone else. So things to think about, again, working with a trusted financial advisor as well as somebody who does not wish to sell you their own products, that can be a great combination for that. Okay. Now, insurance is a piece of this, and it's an interesting conversation because we often think of insurance as providing us with certain services, but it's also part of our financial picture. So life insurance, short or long-term disability insurance, these each have different stipulations that are based on our policies, but the main thing to note is they're going to cover us financially at different times. Short-term being immediately after a change in ability that may impact your ability to work, longer term further out from that. And then life insurance is something that you may utilize to provide a benefit to your family or a beneficiary that you've designated, or you may actually use it as a option where you say, oh, I have some cash value in this that I could use if I needed to for medical concerns. Thinking about, are these things that I can get through my workplace? Will they continue when I leave my workplace is another particularly important question. So things to note here. Long-term care is that last type of insurance benefit that I mentioned earlier, and it's not available to everybody, but it is typically something that's eligible for purchase after age 40. With that, that's a benefit that pays out a monthly amount over a set number of years, and it's something that you often pay a lot upfront for, but may be useful to you later on. So again, this is not one strategy, it's not one way to do these things, but it might provide you with balance for some of the other financial tools you use. Lastly, I'd say there's some policies that combine short-term, long-term, and long-term care. Short-term disability, long-term disability, and long-term care, and sometimes life into one, where you can kind of adapt or move things around. So again, working with possibly a broker, someone who has knowledge of how to sell those products, but then also working with someone that helps you to make those decisions that's not just trying to sell you something, so that you can get all sides of the story. The last piece I noted on here as well is that these things change over time. So as you get information, more information, you may want to consider what mix of things do I need. And so these policies can be things that you pay over into for a long period of time, but you want to think about how much will I benefit from these in the years that I'm looking at. And so balancing those is important. I mentioned health insurance coverage, and this is not necessarily always as explicitly related to our financial planning, but it does relate to eligibility at different points. So some health insurances you may purchase through an employer or through the healthcare marketplace at healthcare.gov. Others you'll become eligible for depending on age and depending on ability or income. And so I just want to note here, Medicaid, or a state managed form of health insurance that people can become eligible for, this varies greatly depending on the state. But often what you want to focus on with this is that they may have benefits for in-home or long-term care that are only accessible if you're below a certain income threshold. And so what we'll talk about in a moment with the legal benefits and legal planning, there are some times where you may actually be able to become eligible for those things by putting assets in a trust or moving them around so that they have a different legal designation that may allow you to become eligible for Medicaid, even if you didn't expect to. So things to think about when you're doing this. There are professionals that I'll describe that help you to access those as well. Okay, so again, lots of information. Please use those as a reference. Social Security retirement versus disability is kind of this trade-off where we want to make some decisions when we're considering, is it time to stop working, or when is the time to stop working? Retirement benefits are something that everyone pays into through payroll taxes, but they're usually not available till 65, or maybe at a reduced payment if you retire early, or a higher payment if you retire later. Disability, on the other hand, has a longer process, but may be available much earlier than that age. But we may be trading off a couple things where we're saying, okay, this amount is an average of what I've worked for 35 years or up to that many years. That's our retirement benefits that are paid out for life. Whereas Social Security benefit, disability benefits may be a fixed amount that's based on our household size. And so it could end up being less or more than the retirement. So that's something that you would want to consider when looking into both of those as possible options to calculate a financial future. That same issue is mentioned here as well. The last piece I'll mention about it is that when you receive SSDI benefits, they may actually give you access to Medicare or Medicaid as well. Medicare after a 2-year wait period from the time that you're determined to be disabled, or Medicaid if your income is in line with that, and getting a disability determination in certain states will help to become Medicaid eligible. Okay, so lots of information fast, but I'd like to just touch on briefly legal planning as well. This is something you'll really want to walk through with an attorney, but the type of attorney that's worth reaching out to is typically an elder law attorney. And so these are available all over the country. You can access these even if you're not yet an elder. But the main thing to know is that they have experience preparing documents that describe our medical decision-making as well as financial decision-making. So in brief, you can make healthcare decision-making documents with a healthcare professional, like a palliative care specialist, also independently on your own if you have a good handle on them, or with an attorney. And so a durable power of attorney would give the permission to allow someone to make decisions for you if you are incapacitated. For example, our most specific example could be if one was to be unconscious in a coma and there needed to be decisions made for you. There are other varieties within that, and state law is really important in that, hence working with a lawyer is important. But this gives you the ability to have some control over your medical future where you make a decision with a trusted partner, someone that you've designated to do that. Same with an advance directive. This is a document that you can prepare with a family member, with someone that you trust, but that says what your healthcare preferences are. So that can be everything from, I do want these type of services, I don't want these type of services, where you would like to go if possible to receive those, and then also any other details about your experience that you would want people to know in a healthcare environment. Now, the most complex part of this is where that elder law attorney may be the most beneficial to you. And so managing one's estate and what that gives you access to in terms of benefits in your lifetime is quite complex. But the main things to note are that it can help you to preserve, organize, and distribute any assets you have. So that could be anything from a home and vehicles to other things that are your belongings that carry value. It can also be accounts with funds in them. And so the main point I'd like to touch on is that when you're thinking about accessing Medicaid, which again is that state-funded insurance that may allow you to access long-term care benefits like in-home caregivers or long-term care facilities, you can use things like a financial trust. So for example, an irrevocable trust allows us to put assets in a trust for someone else in the future or designated specifically for medical care that are no longer included in your overall wealth. And so that would mean that you would have access to Medicaid if those things were no longer assets under your control. It's a complex system in order to put those types of documents in place, but working with an elder law attorney would be the best way to go about that. And lastly, they can help access other benefits that I may not have mentioned here. For example, veterans benefits or other retirement benefits for public service and things of that sort. So again, elder law attorneys and programs are a wealth of knowledge that I would highly recommend. So it's been a whirlwind. Thank you for your patience with going through this. I'd like to just kind of sum up to say the biggest things that we want to do when we're thinking about financial planning, there's so many details and that we can get into, and same with legal planning. The main things are, what are my present goals? What do I need right now? And then what do I think I need in the future? What might change or what do I anticipate? can also focus again on what gives your life meaning and purpose. These are the things that drive our decision making. It can be family, it can be our children, it can be things that we love to do or things that we would like to do that we haven't gotten to do. And so including those in our planning is important because it helps us to understand, actually, this is about living out our desires and our motivations, not just organizing our money or organizing the things that belong to us. And lastly, as I've said a few times, this is a complex issue. So working with professionals can really ease that burden when it comes to decision making. But again, I cannot say enough, include someone that you trust. It can really be anyone, but someone that has your best interest at heart and someone that can help you walk through those decisions and talk with somebody who is presenting you with the different options and really understand what's going to be best for you. What do you need? So thank you for your time. I have my contact on here if anyone would ever wish to reach out and discuss this more, or if I can point you to other resources, but I will see you shortly on our Q&A. Thanks so much for your time.
Hi there. My name is Dr. Erica Pitch. I am a clinical professor of physical therapy at the University of California, San Francisco, Department of Physical Therapy and Rehabilitation Science. And I'm here to talk to you about maintaining accessibility and independence in the home. And so let's just jump right in. So basically the main outline is thinking about the who, what, when, where, and how. And the who is, of course, you. And the what is the task or what you need to do. The where is the environment, your home and all those things and where you need to do them. And the how is how we're going to help you stay independent and mobile and autonomous in your home. And there are three main strategies we use. So we're trying to prevent bad things from happening. We're trying to recover or maintain what we can, and then compensate for what we can't, or the fires we need to put out now. In graphic form, we have our Venn diagram because we have the person, the task, and the environment. And movement sort of emerges from the middle of this. And this is like one of the things we teach our physical therapy students all the time. And so the individual includes all those things that make you you, from the medical history to your habits to your movement priorities, what strengths you have and what vulnerabilities we have, and how those can be used to your advantage in order to stay active. The what you need to do are all those things we do in our daily lives, from getting out of bed to using the bathroom to washing your hands and most body, all your other body parts, to walking, to getting up from the floor, standing up, having a meal, getting dressed, all of those things. How can we keep doing all those things as independently as possible for as long as possible? And then the third thing is where. So in your home, and what kind of home is it? Is it a condo? Is it a house? Do you have stairs or not? All those things that you need to think about in terms of being able to navigate your environment and do all those things that you like doing and need to do, both in your home and out in the world. And so how do we do those things? So depending on time and with a neurodegenerative condition, rate of progression, and again, and this also is just aging, right? So we tend to slow down as we age. And so these strategies also work for just humans on the planet, is that we're always trying to think about these three things. Is what are we trying to prevent? Well, especially, with older adults with any kind of neurologic condition, especially, we're trying to prevent falls. And if someone needs more help, we're trying to prevent caregiver injury as well. But also early on, at any point in time, we're trying to prevent atrophy. We're trying to prevent losing mobility, because we know that, lose it or use it or lose it applies here. And so all of us are just trying to prevent deconditioning by staying active. And that's where we get in this green zone about maintaining. So we're trying to maintain our fitness, maintain our walking ability, our balance, our mobility. And this may be, can become more and more difficult as things progress. But so the strategies may change over time, but especially early on, we're really trying to stay, keep as much activity as possible to stay high functioning as long as possible. And then as things become more difficult, we may do things differently. So compensation means both doing things differently just to get the job done, or maybe using different things or making environmental adaptations. So like grab bars or walking aids, or maybe even a wheelchair to get to point A to point B. Or it could be just like sitting down when you put your pants on instead of one leg. And so the question to ask too is asking yourself, what's important? How important is it that, and what is important? Some people really, really care about not using a device. Others are just like, whatever, I just want to get there easy and quickly. So, let me get the scooter, even if they can walk. So what's important for you? And how do we want to get there? The other thing is, what are you willing to compromise on? So sometimes maybe walking without a device is really unsafe. And so you might be compromising safety for the sake of not using something, or for pride. And also thinking about how these decisions are also affecting loved ones. I've worked with a lot of folks whose caregivers are just, scared because they insist on walking without something, and they're falling frequently and potentially hurting themselves. So sometimes it's being able to use a device not only for your own safety, but for your caregiver's peace of mind or your loved one's peace of mind. So some examples are for folks who may live in an environment where they have a home with 3 levels of stairs. So compensation is either, taking more time to climb the stairs more slowly, or putting in grab bars, or even putting in a chairlift if it's super important to stay in that one home, into that home. Some may really prioritize when they go out, being dressed up, having their makeup on, or wearing the suit and tie. Well, as things get more difficult, that may take more time. So the compromise is taking the time, getting up earlier, planning more ahead to have the makeup on. Or is it, maybe I'll wear, different shoes that are more comfortable but still nice looking. Or maybe I'll, wear a different shirt that does not require as many buttons. Or maybe even asking for help. And that is okay, and being able to accept when you need help. Some families, the family member may be able to stand up easier with some support, or like a lift or a cushion to make the chair a little higher and easy to get out of, but it offends another person's sense of aesthetics about, or putting grab bars, they don't want it to look like a hospital. Well, are you compromising safety for looks? And maybe you can find something that might be easier to get out of that also looks nicer to you. So it doesn't have to be all or none. Other folks, they're overcooking and they'd rather delegate, get prepared food, or maybe, move to a facility that does, that provides meals, or does the cleaning, or maybe hire a housekeeper if you can, so you can delegate that chore to someone. Or if you really, really like cleaning or cooking, maybe you can, start doing some of your prep sitting down instead. Like I said before, others really don't want to use a cane or a walker. But you may find that, I can walk faster and better when I have some support, or using the shopping cart. You find that things are, walking is more easy with a shopping cart. That's pretty much a shopping cart sign of it's time to use a rollator. Other folks, again, when it comes to that, they're really determined to toilet independently, maybe using a bidet instead, or occupational therapists have tools where you can clean yourself a little bit more easily with some adaptive equipment. And that's a way of just using compensatory strategy to still get the job done. And just thinking about like how you might be compromising. So again, thinking about like it may take time, but also being willing to accept help, or accepting risk. If you're really, a high fall risk and you insist on not using a device, then you are realizing that you're sort of risking injury by falling. And again, being able to sort of make, these are tough decisions to make, but it's important to consider all your options. One way of doing that, like in terms of maintaining mobility and accessibility in your environment, is using equipment. And this includes grab bars, ramps, and lighting. So there's a lot of different sort of grab bars on the market now that might look a little, blend in a little bit more with your environment and be less obvious. And there are a lot more portable ramps that don't require a complete front yard remodel now, but you can get those just set up relatively easily. Also, things to consider about in your home, and again, this is recommended from the CDC as well, is just watch out for those throw rugs. The best way is just not use them. If you have to, there's like rug grip things, but typically even that can rumple up. We love our pets, but maybe ask your family to put them away when you're visiting, or sit down first before you unleash the hounds. Marking those step ups in the yard where you can catch your feet. In the bathroom, repeat after me, the towel rack is not a grab bar. The towel rack is not a grab bar, not load tested for humans. These are. Or you can use like a 3-in-1 commode that can go over the toilet if you are renting or your landlord won't install grab bars. Equipment choices or chair choices. I'm surprised by how many people love their rolling chairs, but actually not really. If you must, be sure it's against the wall when you sit down, or grab the armrest when you sit. Plopping in the chair is fun, but you can go flying. So use caution, and better to use chairs that don't plop, slide when you sit down in them. Okay. There's lots of different options. And so consult with your occupational therapist or physical therapist for modifying your home. They can even do a telehealth visit where you can actually just like kind of walk them through your home with your phone. So getting ideas about what to do and problem solve with you. There are a lot of different options for getting out of bed. So there are just like vertical like transfer poles, or even bed rails you can insert under the mattress to make it easier to get out of bed. And of course, lighting, even like motion sensitive night lights are great. You can purchase them online, and they're relatively easy and a nice safe way of getting up at night. Other things behaviorally can do, just so you can do things by yourself. So sitting down when dressing, or sitting down when you're preparing a meal, and prioritizing and picking your battles. A lot of people really want to stand on one leg to put their pants on. How long does it take? What are the consequences of failure? It's probably faster and easier just to sit down and put your pants on and then move on to the next thing. So you can save your energy and risk for the fun stuff. And again, on walking aids, like using things like a walker or a mobility device, if you're avoiding an activity because it's too scary, you're afraid of falling, or it takes too long, then it's probably time to use a walking aid. You want things to make your life safer and more efficient. And your PT can help you figure out what device is right for you at the time. So maintaining mobility, what you can do actively. The most important thing you can do is to stay active by any means as possible. This means exercise. It means just activity and movement as a habit, because we can't guarantee that exercise will slow the progression of the disease. But we know that if you stop moving, atrophy happens. Atrophy. Yeah, I know. I can hear the groans from here, and it's a recording. Atrophy happens. So keep moving by any means necessary, wherever you're starting. What exercise is best? First tier, the one you'll do, whatever your ability. So that may be taking short walks in your home. That might be boxing if you like boxing. Or swimming, or going for a walk with friends. Some folks really like yoga, especially the planks are great for core work and strength. Or working with your trainer. If you had to sort of prioritize, think again about specificity. So what's important, what's the most difficult, and what do you miss? What's missing from what you do already? So if you really like your cardio, great. Maybe adding some strengthening. If you really like your stretching, then you really need some cardio. You need to get moving. And by cardio, I mean anything that gets your heart rate up. Large major muscle groups. This can be walking, stationary biking, dancing vigorously. What kind is better is the one you're trying to improve. So consider the humble sit to stand. So for someone who has trouble rising just once, then doing it 5 times in a row, that's going to make your muscles tired, and possibly even as like resistance training. It is very task specific. And if you're not holding on, it's using your balance. So even just doing that repeatedly is a great exercise. If it makes your knees hurt, then do a small one or hold on. But it's very, very functional and very, very practical. Other examples, For example, if you're doing a slow, easy stroll for someone who can walk without a device, it's not necessarily going to be cardiovascular resistance, but you're going to be working on walking. You're still working your balance, and added bonus, you're getting nature and social time, right? Conversely, that same slow walk, like we said, that might be an endurance activity for her, and it's still very specific to walking. And even though she's holding on, she's still trying to be upright. And so it's still working balance in some degree, and it's challenging her. So just trying to do more frequent walks in the house might be where you're starting. Whoops, sorry, too fast. Other people are really interested in Tai Chi. Great for standing posture, great for self-defense if someone attacks you really slowly. Very specific for balance, and weight shifting. It's also good for coordination and learning, but again, it's not going to be very much cardiovascular resistance training. So it'd be good to get some walking in, or even like the recumbent bike in addition to that. And of course, my favorite is dancing, because move it quickly enough, it's cardiovascular exercise. It's very specific. It's also working balance because you're changing direction a lot. And rhythm also has a whole bunch of research on it, especially music and rhythmic auditory cueing is really good at driving movement, especially like familiar songs. There is some work on Parkinsonism, a lot of work on Parkinsonism actually with music. So especially for the Parkinson-like variants, music can be really, really helpful. And for everyone, it's great for exercise motivation. So whether it's chair dancing or standing dancing, either way, moving through space to music is good for all kinds of body parts. Exercise does not have to be complicated, it just has to be done. Think of it as medicine. Like literally, it is probably one of the most powerful things you can do. And if you don't like to call it exercise, call it movement. Just a little bit of movement. Whether it's your walk after every meal, whether it's, literally, I keep thinking about putting like old strips of paper in medicine boxes, like fortune cookies. It said, oh, it's Friday and it's blue, so I'm going to work on balance, or, green is a walk. But think about what medicine I'm going to take today. And when in doubt, take a walk, walk around your home, even just a little bit, every little bit counts. There's lots of other online options now as well. There's YouTube videos of Sit and Be Fit. There's community programs like Silver Sneakers, which affiliates with 24 Hour Fitness in terms of having classes for older adults. So be sure to check your community in terms of senior centers for ongoing classes, because there's quite a few of them available. Okay, when to see a physical therapist? If you're newly diagnosed and don't know where to start, that's the best place. So we can exercise early and often and give you some specific things to work on. If you've never seen a physical therapist and you're wondering, is it time to get that device, or you're worried about falling or afraid of falling, that's the optimal time. If you've already had a fall, definitely come see us. Don't expect to be seen by physical therapy forever. It does have a start and an end period, but ideally, in an ideal world, we would start people on physical therapy, get people going on their exercise program, and then discharge them for now, knowing that you're responsible for your exercise program and you're just going to continue that. Just like when your physician prescribes you a medication, you take your blood pressure meds, and make sure they're working. Okay, nothing to change. You just keep going with that. But then you come back in for a checkup in 6 months or a year. We do our standard measures, like your physician does checks your blood pressure. We check your sit to stand, your walking speed. We do some standardized balance measures so we can track you. And that way, if something starts declining a little bit, we got to intervene. We got to get you back on track and maybe sort of make the exercises a little bit, you got to upgrade your exercise program. Be careful when you say things are easy, because your therapist, if they're a good one, will make it more challenging for you. If you say it didn't work, wonder, am I getting tired with the exercises? Because they're supposed to make you tired. That's okay. Yeah, I actually had somebody say, yeah, those exercises are really tiring. I'm like, you say that like it's a bad thing. Your body actually needs to get tired for it to get better. So if it's making your muscles get tired, that's a good thing. Okay, went to see an OT. So my colleagues in occupational therapy, they are great for all things dexterity, all things activities of daily living. So if it's meal preparation or getting your clothes on or bathing and dressing, all those things, or executive functioning, like, adulting. I think they used to have people write a check. I'm all, maybe teach them how to do online billing. So they're all things on activities of daily living. Some also do driving assessments. So they can, and they are the kings and queens of gadgets in terms of adaptive equipment for eating and dressing. So adjusting spoon handles that are hard to grip, or just using foam handles and things like that, or dressing tools. So they are your friends in that department. All right. So summary, taken together, I'm watching the time here. Prevent atrophy, falls, and decline as much as possible by staying active. So prioritizing what's important for you. Compensate for the stuff that's not important, you just want to get done. Make it easier and safer. Spend your time doing the things that are really important. Use equipment to make your life easier. Stay active. Every little bit counts. And see a rehab professional for help. The CDC has great resources for fall risk assessment and questionnaires, and other recommendations on environmental modifications. If you want to find a physical therapist, go to choosept.com. And final thoughts, I'm from a family of people who write really bad limericks. So if you are afraid you will fall, it is tempting to not walk at all, but stay strong and stay fit. And for gosh sakes, don't sit, get up, get moving, stand tall. I am Dr. Erica Pitch, and this has been Maintaining Mobility and Accessibility in Your Home. Thank you.
Hello, I'm Dr. Claudia Chow. I'm a hospice and palliative medicine physician at Mayo Clinic in Rochester, Minnesota. I'm here to talk about the role of hospice and palliative medicine in MSA. I have no disclosures. The objectives are to define hospice and palliative medicine and to discuss the role of hospice and palliative medicine in MSA in relation to symptom management, advanced care planning, and caregiver support. So what is palliative medicine? It also goes by palliative care, and we can talk about that in a little bit. It is a team-based model of care for patients with advanced or progressive illness. It focuses on providing relief from the symptoms and stress of that illness through preventing or relieving suffering. Palliative medicine is made up of a number of core team members, which really makes it a multidisciplinary approach to care. These people can include physicians, nurse practitioners, physician assistants, registered nurses, social workers, and chaplains. Now, palliative medicine is a term that many people may not have heard of before, and there may be a lot of anxiety and worry associated with meeting with palliative medicine for the first time. It's usually helpful to review a few key points to begin with. Palliative medicine is multidisciplinary. It is patient and family centered, and it does focus on quality of life. It is not akin to giving up. It is not the last resort just because there are no other options available, and it is not the same as hospice. Now, I'd mentioned palliative medicine may also be called palliative care or supportive care. Really, these are all terms for the same team of people who have the same goals. It really may just be a difference of which institution you're seeking care through. The goal of all of these teams is to improve quality of life for both patients and their care partners. We understand that quality of life means different things to different people, and so our goal is to figure out what is most important to you. So I've talked a little bit about the fact that palliative care is different than hospice. So what is hospice? Hospice is continued whole person care through the last phase of life. That generally means it is for a patient who is in the last 6 months of their life, as far as we can estimate based on our knowledge of the patient and our knowledge of the disease process. We realize that no one can predict the future with any certainty, and so this 6-month prognosis is really more of a Medicare guideline. We certainly have patients who live beyond that 6 months, and they can still remain on hospice as long as we anticipate that they will continue to decline and thus remain hospice eligible. Hospice is for patients who are no longer seeking curative or disease-directed therapies, or for patients in whom further therapy is not an option. I know that can be a little bit confusing too. knowing that there are a lot of diseases, often in neurology, that don't have any curative options available right now. In our patients with cancer, certainly this can make a little bit more sense if chemotherapy or other sorts of cancer-directed therapy are not being offered. For our patients with neurologic disease, this often means that they are no longer at the point of seeking further clinical trials. It may mean that even routine visits to primary care are no longer thought to be helpful, or they might be more burdensome than helpful. It is for those patients who think that even in case of sudden decline, where one would ordinarily call the emergency department, our patients are thinking that even that might be more burdensome than helpful and detract away from their time at home. Hospice does bring team-based care to where patients call home, whether that's in their own individual home, in an assisted living facility, or a skilled nursing facility. Certain types of hospice cares can even be carried out in the hospital setting. Our patients on hospice have access to the hospice team 24 hours a day, over the phone, and sometimes even in-person visits. The philosophy of hospice is that we are adding life to days as opposed to days to life. Hospice is comprised of a number of team members as well. This includes physicians, who may be called the hospice medical director, nurse practitioners, physician assistants, registered nurses, social workers, counseling in the form of spiritual care or chaplaincy, dietary or bereavement services, pharmacists, volunteers, and hospice aides. So when is the ideal time to involve palliative medicine? Palliative medicine is really based on a patient's needs and not their overall prognosis. And so if a patient has needs in terms of symptom management, decision-making, or support for themselves or their loved ones, then it is a perfectly appropriate time to consult palliative care, even from the time of diagnosis. We can provide care alongside patients who are seeking curative treatment as well as clinical trials. Why does palliative medicine make sense for patients with MSA? Well, we recognize that neurologic conditions, including MSA, tend to have a high symptom burden. We know that MSA has a variable disease course and it changes over time. Every patient's course with MSA may look different, and even within one patient, there are going to be periods in which they have different symptoms, the symptom burden is higher, things may feel like they are in a place of stability, or things may feel like they are progressing more quickly, and we can help navigate all of those challenges. MSA patients may be faced with difficult decisions regarding their care. And we know that MSA affects not only patients, but also their families and their caregivers. So what could palliative care offer you? We really think that we would offer a symptom assessment with treatment recommendations and management, coping, counseling, and assessment for caregiver distress, and help with advanced care planning. We really have that 10,000-foot view. In terms of symptom management, what might this look like for a patient with MSA? We recognize that pain and other distressing symptoms can be a part of serious illness. We talk about the experience of living with MSA. How are things going on a day-to-day basis? What are the things that are most difficult about this disease? We recognize that illness affects someone's spiritual and emotional health as well. And we offer a support system to help patients live as actively as possible for as long as possible. My patients with MSA recognize that there is a large symptom burden that comes along with MSA, and certainly a lot of those symptoms are physical. They may be talking to their neurologist about a lot of these symptoms and talking about different medication strategies. They may be speaking with physical medicine and rehabilitation about physical therapy, occupational therapy, and speech therapy. They may be thinking about adaptive equipment. They may be seeing sleep medicine or urology. We recognize that the care of MSA is complex and really takes a multidisciplinary approach. Even though we recognize that the symptom burden in MSA is very high, a lot of those are physical symptoms, and patients are certainly made up of more than just their physical bodies. We recognize that there is the spiritual self as well. Where does someone fit into the greater world? How are they coping with their disease and what might happen next? These are perfect questions for our palliative care chaplains. We recognize there is a psychological toll that comes with serious illness. Depression and anxiety are very common in the general population, and certainly these can worsen when we are living with serious illness. Patients and caregivers may need to think of different ways of coping with their illness. They may need to think about looking at our social work resources, thinking about individual or family therapy or counseling to work through some of these issues. We recognize that there is the social and practical aspects to life as well, and none of those stop just because we're living with a serious illness. Our schedules continue on. There are always appointments to happen and bills to be paid. We recognize that social relationships may change as well. Some friends may become closer and some may pull back. Social engagements may become more difficult. A lot of patients really identify work as being very important to themselves, and many are not able to keep working in that way anymore. That can be a loss of community and some form of purpose. We recognize that hobbies can change as well. So there certainly are a lot of losses that come along with serious illness. Finally, we recognize that there are issues of coping, counseling, and caregiver distress. I mentioned this a little bit in that psychological realm on the previous slide, but of course the effects of serious illness extend beyond just the patient, and we try to offer a support system to help family cope during the patient's illness. We can talk too about planning for the future. It's difficult to give an individual a prognosis, and we expect over time that all patients will require more help with mobility and daily activities. And it's important just to begin to start to think about who might be able to provide that extra help and where that will occur. Are there family members who may be able to move closer or even into the home to help provide that help? Would we be thinking about external sources of help, such as paid caregiving, or even moving out of the home into a sort of care facility? This brings us to the topic of advanced care planning, and this also goes by the term advanced directives. This gives patients the ability to appoint a healthcare agent to make healthcare decisions for themselves if they cannot speak for themselves or cannot decide. As long as our patients are able to talk to us and understand what's going on with their healthcare and express a choice, then we will always turn to our patients first. However, we recognize that involving family members can be very important at certain points in a patient's disease. Advanced care planning allows patients to state their wishes about the type of healthcare they want and share those wishes with loved ones and the medical team. As hard as these conversations are to have, it's easier to have these conversations when a patient is feeling relatively well and can participate, rather than when they're in the midst of a health crisis. I want to emphasize that this is not a single conversation, but this evolves over time. Planning ahead can be a gift that our patients give to their loved ones by outlining their wishes and giving a plan to be followed through. Some patients might complete advanced care planning alongside other legal documents, such as a financial power of attorney or wills. This all falls under the scope of estate planning, which can be done with an attorney. However, for the medical aspect, it may be important to still continue to talk about the healthcare aspects of this paperwork with a healthcare professional. So how do you complete your advanced care plan? Of course, there are a significant number of factors, including the state in which you live. There can be variability in the different forms and the different questions that are asked on the forms. At a minimum, naming a proxy decision maker is vitally important while a patient is still able to make medical decisions. Forms may require a notary to sign them in order to make them legal. They may require witnesses, so read your individual form carefully to make sure you're filling it out correctly. And you can discuss those medical aspects with your neurologist, your primary care physician, or with palliative care. There is one document that extends across a number of states and at last count was legally valid in 36 states, and that is the 5 Wishes document. You can Google this online. There is a cost with ordering the document to come to your house, but we found that this is very helpful in breaking down some of those big questions that are asked in an advanced care planning document. This allows you to name a surrogate decision maker. It allows you to talk about the kind of medical treatment you do want and also protect you from the type of medical treatment you don't want. It talks about how comfortable you want to be, how you want people to treat you, and what you want your loved ones to know. I often tell my patients that this is starting a conversation and that this evolves over time. We recognize that there are difficult decisions that may need to be made in a patient with MSA. Commonly, these can include decisions around a feeding tube, which is also known as a PEG tube or a gastrostomy. For patients with breathing difficulties or stridor, we may be talking about a tracheostomy or a surgical airway. I want to emphasize that these are deeply personal decisions for each individual. This often requires multiple discussions with the medical team and loved ones about what life might look like with these interventions. How will day-to-day life change? We encourage our patients to learn from the experiences of others. Our patients are wonderful teachers for us, and they're wonderful teachers for the community as well. Organizations like the MSA Coalition will have resources to help talk you through some of these decisions. Learning from other patients with MSA or others who have gone through similar decisions in the past can be an invaluable source of support and information. We also talk about a patient's place of care in terms of difficult decisions, and sometimes that means a transition out of the home setting to a place where they can receive a higher level of care from trained staff. Our care transitions can occur to places like assisted living, long-term care, and hospice, with different levels of support offered at each one of those levels. Now, I brought up hospice, and I wanted to talk a little bit more about hospice, just like I had talked a little bit more about palliative care earlier. When I bring up hospice, I hear some common concerns, and so I wanted to address those here today. I've heard that hospice does nothing. And I would say that hospice believes that patients and carers deserve whole person care through the end of life. So just as in palliative care, we thought about the spiritual self, the psychological self, and the social and practical needs, we continue those cares in hospice, helping patients walk through that phase of life. I've heard that hospice takes all of your medications away. And in my practice in hospice, hospice will help figure out what meds are truly necessary to control symptoms and promote comfort. My patients on hospice are at the point in which comfort becomes the primary goal, and so it's worthwhile to look at the medication list again and really keep only what's necessary. I've been told that hospice only gives you morphine, and I would say that morphine is one of a number of medications that could be used to promote that comfort. And we only dose medications to reach a certain level of comfort, which is the patient's desired level of comfort. So our goal is not to speed up or slow down the natural dying process. Hospice means there's no hope. And I would say that for my patients on hospice, cure might no longer be possible. But we help define what other types of hopes there might be, whether that's comfort, time with family, or being at home. Hospice can help meet goals in that way. So my patients will often ask me, is hospice right for me? Is this the path forward? And I would say we need to take a step back and look at the bigger picture. Again, working with a medical team that knows the patient well, that knows their values and preferences, or can ask questions about their values and preferences regarding their care. Working with a medical team that knows what MSA might look like, and really asking questions to see if hospice is the right fit. It's usually not just a yes or no answer, but it's a conversation. And so I wanted to end with how to even get access to these resources. How do we get palliative medicine? I would say start by talking to your loved ones about your wishes. Start to document the things that are important to you as you think about your care. That's something that can happen within a palliative medicine visit. That's something that can happen outside a palliative medicine visit. If you wanted to see a palliative medicine specialist specifically, I would say start by talking to your neurologist or primary care provider. There may be local palliative clinics in your area. When it comes to that point where you might be thinking about hospice, my patients might ask me, how do I get to hospice? Well, we would say you can talk to your neurologist and or primary care provider first and foremost and say, do you think hospice makes sense at this point in my disease? They should be able to give you a sense of what they have seen about your disease, what they have seen other patients go through, and again, put that in line with your wishes and preferences. And that brings me to my next point. Talk to those who know you best. Knowing that hospice is a form of care that focuses primarily on comfort, are we at that point where comfort is our number one goal? I did link here to the Medicare Hospice Finder, and honestly, just putting this into any search engine will pull that up. Medicare Hospice Finder will bring you to this website via Medicare where you can put in your zip code or your city and pull up a list of the hospices serving your geographical area. Hospices tend to be very geographically based. Patients can also self-refer to hospice and just talk to a hospice about what their wishes are and perhaps have a meeting face-to-face to discuss more if hospice is the right fit at this time. I did want to mention some other resources. We talked about the MSA Coalition, and then we also have some more palliative care specific resources. Get Palliative Care is a great resource. Through Caring Info, you can look for your state's specific advance directive form. I'd mentioned 5 Wishes before. And we have a newer society called the International Neuropalliative Care Society, which aims to be a resource for palliative care in neurologic disease for all patients, all providers, all care partners, and all advocates. So it's a lofty goal, but they are working on being that resource. I wanted to say a huge thank you to Dr. Laura Rhee, who is one of my palliative medicine physician colleagues. She and I put this talk together a few years ago. Dr. Elizabeth Kuhn is our MSA neurologist. We are well supported by our neurology nurses, Tricia Stevens and Carrie Nagel. And then I wanted to thank you all, the patients, care partners, and MSA Coalition who make our care possible and for whom it's a privilege to serve. Thank you so much.
A sincere thank you to our outstanding speakers, Spencer Deal, Erica Pitch, and Claudia Chow. Your wealth of knowledge, passion, and dedicated commitment have significantly enhanced our understanding of financial and legal considerations, maintaining independence at home, and accessing palliative and hospice care. As we bring this enlightening session to a close, I invite each of you to actively engage in the live Q&A session that will immediately follow. Your questions are not just welcomed, they are essential. Our speakers are eagerly standing by to address any queries or reflections you may have. Before we part ways, I want to make you aware of a valuable resource that we have prepared for you. In addition to the topics covered today, we understand that there may be other aspects of planning for the future that are important to you. That's why we've put together a comprehensive resource guide touching on a myriad of subjects not covered in today's session, whether it's advanced healthcare directives, estate planning, or community support resources. Our guide is a repository of information designed to assist you on your journey. We encourage you to explore this guide at your convenience and feel free to reach out if there are specific topics you would like more information on. Remember, we are here to support you not just today, but throughout your ongoing journey of planning and preparation. Thank you for being an integral part of this session, and let's continue our conversation in the Q&A session. Your questions are the keys that unlock deeper understanding, and your active participation is the lifeblood of our community.